It's my pleasure to introduce Dr. Esther Vivas. She is giving her talk today from Emory, and she'll be talking to us about otologic manifestation of IIH, and we're really glad to have her here today with us.
Thank you so much for this invitation. It's really quite an honor to be presenting to this group. I remember interviewing at the house for fellowship back in the day, and it's just kind of so special to be asked to talk today. And something that I see often in my clinical practice, much more than I had anticipated during my training and fellowship. I didn't think I'd be managing so many or just seeing so many of these patients. So at least in this part of the world, in the country, we see quite a bit of IIH and how it interplays with our specialty. I have no disclosures. A little bit about my background. I was born in South America in Colombia, and I moved to New York City when I was very, very young, and I've done my training. I've had the luck of kind of being all over the place, whether it was in New York for my undergrad and my residency. I had a little bit of time in Europe, and then ultimately ended up back in the Bronx for my medical training in Pittsburgh for fellowship. And when I graduated fellowship, I came directly to Emory, where I've been since 2013. And I run the lab and our temporal course here. So I've been very happy down. I guess now I'm a Southern girl. So the first thing I want to go through is the nomenclature for what we now call IIH, or idiopathic intracranial hypertension, has really changed over the years. It was initially referred to as serous laryngitis, then pseudotumor cerebri, which we still often see reported. Now, pseudotumor cerebri has a very specific diagnostic criteria that is now separate from what eventually became known as IIH. We also have seen it referred to as benign intracranial hypertension. However, that name is no longer preferred because it's not necessarily a benign condition. It does have morbid manifestations. And so now we are really transitioning to trying to be more standardized in the way we refer to it as idiopathic intracranial hypertension, IIH, and that's how I'll refer to it from now on in the rest of the presentation. So why is it relevant? Well, the incidence is anywhere from 0.5 to 2 per 100,000 people per year. However, that number really changes if you're focusing on the specific young obese population who are female. And if you look at that group, the incidence really rises anywhere from 12 to 20 per 100,000. So a big jump when you're focusing on this particular pathology. So the prevalence in women is really 9 times the prevalence in men. It's a drastic difference. And the mean age of diagnosis for classic idiopathic intracranial hypertension is actually young childbearing years, 2nd and 3rd decades of life. Now, why is this so important? Well, the rates of obesity in the US have tripled between 1990 and 2006. And obesity has a linear correlation with the elevation of intracranial pressure. So this is from publication in Ophthalmology Journal, where you can see the linear correlation as the body mass index noted down below increases, so does the intracranial pressures. So this comes into play as we develop the story of how this manifests in the otolaryngology practice. What's interesting, and something that I didn't really fully wrap my head around regarding obesity in general, is that it's now understood to be an inflammatory disorder. There are numerous cytokines that are implicated in this metabolic disorder, specifically adipokines, which are found in adipose tissue. And also, there have been markers of inflammation identified in patients who are diagnosed with idiopathic intracranial hypertension in their CSF. Specifically, chemokines like the CC motif ligand 2 have been found to be significantly elevated, and these chemokines are involved in inflammatory cascades and have been implicated in a number of different diseases, including autoimmune disease like rheumatoid arthritis, psoriasis. And so it's, we're trying to piece together the underlying pathophysiology of how obesity and IIH can be related. We know they're related, but exactly how is still to be understood. Now, in the US, this is particularly a problem because, as you can see in this chart, the US is by far one of the fattest countries in the world, with China coming in second. And you can see my little sad and happy faces here where you guys are, or many of you are in California. The obesity rate is the lightest in the country. That part of the country has really not very high rates of obesity. However, in the South and the Southeast, where I'm located in the state of Georgia, our obesity rates can go up to 35%, depending on the county that you're in. And so the obesity problem is very relevant to our patient care population here in Georgia. So what is the thought behind obesity and the development? There's this development of IIH. Well, the classic thought is increased weight gives you elevated intra-abdominal or intrathoracic pressures, and then that leads to an increase in central venous pressure, which decreases the absorption of CSF, and that, bam, gives you elevated intracranial pressure. So it sounds pretty logical, but what is the problem with this? The problem is that this does not explain why females are predominantly affected. We have just as many obese men and women, and if you put those in a group, the ones that develop IIH are going to be primarily the female. So there's obviously some sort of hormonal influence that we've yet to delineate. So whether it's elevated CSF production or decreased CSF, increased CSF production or elevated absorption, how does that interplay with the female gender? Well, I'm not going to be able to answer this question today. I'm going to tell you there is that correlation. And I think it's very interesting because, Dr. Dandy was the first one to describe this phenomenon. And this was in 1937. It's a case series. It's actually really interesting. And I recommend you guys, it doesn't take too long to go through. But he describes in detail each of his patients that he diagnosed with what now we call IIH. And he said, this pressures just change very briskly, become very elevated, and then they go back down to normalized levels. These patients present with headache, dizziness, pulsations, and at the end of the day, we really don't know why this is happening, and there's not much more that we've been able to figure out some stuff, but really at the end of the day, it's still largely idiopathic. So what do we know so far about IIH? There's a nice study that came out of the Lancet several years ago where they looked at, it was basically meta-analysis. They gathered data from numerous large trials or studies rather, from all over the world, including the USA. And they formulated, they just reported what are the top symptoms identified in these patients. Well, not surprisingly, headache was, almost everybody or the vast majority, obviously some ophthalmologic manifestations, which is really one of the most feared effect of this disease is going blind. But, as you can see, the majority also had pulsatile tinnitus, they had dizziness. And so these things are, these symptoms are obviously in our repertoire, and that's how we end up seeing a good number of these patients. Now, the pulsatile tinnitus, just so you know, it's primarily bilateral. About 2/3 of the patients will have bilateral, but some may present with just a perception of it being in one side of the head or the ear. There was one large, the first prospective clinical trial, multi-center, came out of the UK looking at IIH patients and the effect of acetazolamide with weight loss, specifically looking at the benefit of improvement in their visual symptoms, their headache, and the quality of life. And this is called the IIH trial. And so you can see that the symptoms here that from that large trial are very similar to what I just showed you from the meta-analysis. Headache being the primary symptom, followed by, you see pulsatile tinnitus and here pretty equally present in these patients. We can also have things like neck pain, cognitive, fog, brain fog situations. And so, the repertoire of symptoms that come to us are pretty prevalent in these patients. Now, what is the classic diagnosis? What you saw typically reported that was a requirement to actually diagnose this condition was the symptoms or the findings noted here. Papilledema, palsy of the abducens nerve in the setting of an otherwise normal neurological exam, no infectious markers found in CSF, pretty normal composition, and a lumbar puncture that is actually identifying an elevated pressure of 25 or greater. Now, this is for adults. The pressure threshold for pediatric population is different, and so we're only focusing on the adult population here. What do we have currently available for the management of these patients once they are diagnosed with IIH? Is that weight loss and lifestyle modifications are usually recommended at first-line treatment, but as we all know, weight loss is quite a difficult endeavor for many individuals. And so the medical aspect comes into play pretty quickly because many patients are not going to be able to shed enough weight to really make a difference in their condition. And so there's numerous different types of medications out there. Some are still considered investigational and used off-label. But the ones that are most common and that we should be all aware of is the acetazolamide and Topamax. Those two actually affect the rate in which CSF is produced and have been found to decrease intracranial pressures. The study that I was telling you about found that at 4 grams, acetazolamide did have an effect in decreasing the pressures enough to have an effect on the visual symptoms and the headaches. Topamax is similar to acetazolamide, but just not as widely used. And the other two there are more of off-label medications that have actually been developed for management of other metabolic disorders like diabetes, for example. And they have a primary effect on weight reduction and also some diuretic effects. And so those two are, you've seen in the literature, you do a literature search, primarily seen in the ophthalmology and neurology literature. And then the ultimate treatment is CSF diversion through a shunt. Now, in the UK, they've had a 100% increase in the rate of patients presenting with obesity and subsequent patients developing IIH. It's a huge number, and because of their sort of centralized socialized medical system, you can say, they're able to keep track of this condition much more closely than we're able to in the US. And they actually came out with these treatment guideline in 2018, which I thought was interesting. And I just wanted to kind of mention it. It is there. However, in the US, our diagnostic criteria and the treatment algorithms are a little bit more varied and decentralized. We do have a new diagnostic criteria that, if you look at the American literature, is much more prevalent now to refer to. And it's out of the neurology literature from 2013, there was a modification, at least in the diagnostic criteria. And why? Well, because we found that there was a lot of different patients that fit the overall global picture of IIH. However, they didn't hit all of the points that were typically required in the classic criteria. So what did they do? They said, well, if you have, you know, A and B, you can have a diagnosis of IIH, but if you don't have papilledema, well, guess what? If you have these other neuroimaging findings that make it very suspicious for IIH, then you can roll in those into your assessment and diagnose these patients without having true papilledema. And that's important because and we're talking about this in our otolaryngology literature. Papilledema is not really something we identify in patients that come in to us with symptoms where we are suspecting IIH. So this is the new criteria that we follow. And because there are very specific neuroimaging findings identified here, we're gonna go through those in detail today because I think they're really neat, and I've got some really nice pictures shared to me from our neuroradiology department. So what are those? Those are empty cella, flattening of the posterior aspect of the lobe, the distension of the perioptic subarachnoid space with or without a tortuous optic nerve, and transverse venous sinus stenosis. So these are the neuroimaging criteria that can be used for diagnosis of IIH in the absence of papilledema. So this is, I think, one of the more fun parts of the presentation is to look at these next picture. So empty cella, by far the most common neuroimaging finding. It does not give you a slam dunk diagnosis of IIH, but it should raise a red flag. It is very common. It's often found as an incidental finding. And so it's thought to, you know, it's not diagnostic, but it really should be the first thing that raises a red flag that there may be elevated pressures, either present or recently elevated. There are reports that there could be reversal of the empty cella if there's normalization of the intracranial pressures. You can see here that we have a CT at the top pointing to a patient with an empty cella. You see compression of the actual gland, flattening of the gland, because there is, you know, herniation of the subarachnoid space into this area and compressing the gland. Some of the findings that I think are pretty neat because they're very obvious and drastic in advanced cases. And this is something that we otolaryngologists can easily look at on MRs once we know what to look for. And the orbital findings are as follows. The first one to consider is posterior globe flattening of the optic nerve head and optic nerve head protrusion. As you can see in the arrow here, this area should be nice and very, very circular, and it's kind of flattened out there. The next would be the sheath enlargement. This is a pretty nice picture because it's very obvious that the optic nerve sheath here is quite thickened. This should be, you know, quarter of the size in a normal patient or a third of the size. We have optic nerve head edema with some enhancement in the surrounding area. So you can see this area, the edema is very nicely shown here. And, you know, particularly interesting to look at is the tortuosity of the optic nerve itself. And so once you can see this could be easily picked up by us if we're just looking at MRs that picture the globe in a good way, right? What other findings? Well, there are numerous skull-based findings that we can look for. On the top right on the screen, you can see we have a CT bone algorithm here, and it's so obvious in this particular image, obviously, because I have it for show and tell, but you can see the bone looks almost as if it's been bitten away by a mouse or rat, just kind of, you know, teasing away at it, eating away at it. So it's very, very heterogeneous in the surface here. And those are thought to be due to prominent arachnoid pits. And, you know, it can have different ranges. It can be very mild and easily missed, or it could be as obvious as what I'm showing here. Now, these pits can then lead to osseous dural defects and meningoceles. They can really occur anywhere along the skull base, but obviously there are areas around the cribriform, the nasal cavity, and in the tegmen towards the lateral skull base, where they are much more vulnerable because they're thin as it is. And so those meningoceles, can be present in multiple areas. So it's good surveillance. It's a good practice to surveil everything, not just the lateral skull base, but oftentimes these patients will have multiple areas that may need a team approach in management. So it's important to be cognizant of that. This particular MR is showing a cribriform plate meningoencephalocele. So rhinorrhea is often a presentation if it develops into a CSF leak. Now you can also have meningoencephaloceles in the petrous apex. And here you're seeing something in the right side is obviously bright on MR sequences, T2s, but you can see them along the facial nerve. This is a meningoencephalocele into the area of the geniculate. You can see the corresponding MR sequence right here. Those are much more rare, but they can happen, and you want to make sure you're able to have a diagnosis that doesn't commit them to specifically a tumor, hemangioma, or other things like that you can also see in the geniculate. You can have enlargement of the skull base foramina. This is specifically pointing at rotundum, but in these patients that have IIH, Meckel's cave is something that is really important to evaluate because that foramina is often enlarged. And it actually is an area where you can have an undiagnosed CSF leak and you'll have failure of your repair because you don't realize that there was also a secondary point of egress because it's a little bit harder to see on imaging. So I've been personally burned by that situation. So now I always make sure that when we're doing our middle fossas, I take a good look at the imaging and look at Meckel's cave and see if there's anything that we need to address there and extend our middle fossa approach to survey that area. And finally, something that is not as relevant to otolaryngologists, but I think it's important to just be aware of is that these patients, they have headache, right? And then they'll get an MR and they'll be like, oh, you have a QRA1 malformation. And so they'll get streamlined to neurosurgery for repair, decompression, and have persistent symptoms. Well, it turns out that there are some of those patients that don't have a QRA malformation. They have IIH, but their tonsils are low-lying. And so they can end up with a misdiagnosis and undergo unnecessary treatment. So that's something I always like to point out so that people can just have that in their radar, even though it's not necessarily in our repertoire of everyday practice. As noted in the new diagnostic criteria, stenosis of the sinuses, specifically the transverse sinuses, is one of the things that we're supposed to be looking for to make a diagnosis. It can happen in the other sinuses, but the transverse sinuses are by far the most commonly affected, and it tends to be bilateral. Sometimes you can see it unilateral, but primarily bilateral. And it's thought that it could be also reversible. So if you normalize the pressures, the thought is that over time, the stenosis can be reversible. So that's important to just be aware of. These arrows are pointing to the bilateral stenosis showing up in this, specifically in the top. And then this is a secondary view. So now that we've gone over some of the cool pictures of neuroimaging that we should all be aware of now, and let's look at the clinical presentation. So these are two patients of mine who presented to the office. Both had been diagnosed with otitis and treated for an infection with rounds of antibiotics with no improvement in their physical exam. And, you obviously can tell this is not a normal looking ear. There's this abnormal tympanic membranes, they're bulging. One looks obviously more full and, abnormal with a red mass filling what looks to be the whole, almost the whole middle ear space. What you do not see on this left, because it's a picture, is that it was a pulsing mass. I did not see any surrounding fluid, but, you're thinking, your differential diagnosis at this point is like, this is probably not an acute otitis media, which is what this woman has been told. It could be, it's obviously some sort of mass, neoplasm perhaps, maybe it's a glomus, maybe it's, an encephalocele, maybe it's some sort of other primary middle ear neoplasm. It's hard to tell. And the right one was not pulsing, and it was relatively asymptomatic. She had a little fullness in the ear, but not like the other patient that just felt her heartbeat, pulsing away. So if we look at the patient on the left side, the imaging was pretty convincing that this was indeed an encephalocele. You can see the brain matter tissue dropping down into the middle ear space and filling this whole area. If you go through all of the T1 and T2 images, you can, it's pretty obvious that it is an encephalocele. And so this is, this was a patient that was ultimately diagnosed with IIH. It was a very dramatic encephalocele. These are not very typical. Usually we see something that's a little bit smaller and it's not always leaking. They can just have hearing loss if it's impingement of the ossicles, or you can have, a sensation of pulse in the ear, obviously. So because when we manage these patients, usually it's either an encephalocele or CSF leak, then, how do we think about the correlation? We know there is an association. And again, the pathophys hasn't been totally teased out, as I've been saying over and over again. But the thought here is that the elevated pressures, which tend to be chronic and intermittent, develop the arachnoid pits that we looked on the imaging, that develop osseous defects. Then the dura is diffusely thinned out over time. And then that as the osseous defects really formalize and enlarge, you can have the development of diverticula, meningoceles, and ultimately these areas can open up and cause CSF leaks. The CSF leaks are not always constant. They are intermittent. Sometimes you'll see patients that say, I've been dealing with this on and off for years. My ear just fills up with fluid. And then it just, I'll take an antihistamine, it'll go away. Not really related to an antihistamine probably, but you can tell that some of these patients have an intermittent problem. And so if you look at the incidence of how many surgeries we are doing to repair these CSF leaks, idiopathic, right? Not traumatic. There's been a significant increase in those numbers. This is a nice little study that was reported, not that, several years ago now, not that long ago, but it showed that there's been a doubling of the CSF leak repairs when you look at the US between 2002 and 2012. And that these patients, unlike the classic IIH patients, remember those are childbearing women, 20s and 30s, these patients are older. They're an average 50 years, they're like in their 5th decades of life. And so they're not similar to the IIH population in that regard. And on top of that, the papilledema is really uncommon. So what do? We partnered several years ago with our Neuro-Ophthalmology service. And the reason we did that is because most of these patients come through when they're not leaking or they have a mass in their middle ear from encephalocele, they tend to come, those IIH patients tend to come through ophthalmology. And we formed what we call the IIH and CSF study group. And we this is one of our more recent publications. And what we did is, we really wanted to delineate it from our patient population. What was the relationship between IIH and the skull-based CSF leaks? Not surprisingly, most of the patients that we treat are women, 94%, as you can see at the top. And again, not surprising, consistent with all the other reports. BMI was high, consistent with obesity. And, this is a breakdown here of the sites where we identified the CSF leaks. And you can see that almost 40%, 39% were actually coming diagnosed through the temporal bone, the lateral skull base, and the rest were coming, either the ethmoid or the sphenoid, with this lowest number out of the frontal sinus. And the ophthalmologic exam, 80% were normal. So we were not seeing papilledema, we're not seeing the torches, optic sheath, the problems with the nerve is just not there in this particular population. And I do want to make note that we are pretty aggressive with the acetazolamide in these patients, and we really try to defer the management of acetazolamide to ophthalmology, and that was part of our working group, because, these folks, ophthalmologists can just throw acetazolamide at patients, like grams and grams on a daily basis, and I think most otolaryngologists are a little bit hesitant to delve into that because of all the potential side effects. And so we tend to defer to our ophthalmology colleagues on managing that, which we're pretty happy with that arrangement. So when we look at the radiographic signs in this patient population, we had divvied them up into the IIH only group and those who presented with the CSF leak, not necessarily diagnosed with IIH, just presenting with a spontaneous leak. And we looked at the radiographic findings between these groups. What we found is that for IIH, if you look at, we have, obviously we found the classic ophthalmologic changes on imaging on the IIH group, which is much more rare in the CSF leak, spontaneous CSF leak group. But I wanted to bring your attention specifically to the bilateral transverse sinus stenosis. 96% of the patients with IIH had that, and it's still a high enough, 68%. At that point we hadn't been getting MRVs on every patient. So at that point we had 25 patients enrolled. We have a lot more by now, but it's still a significant amount. And it was surprising that, we're not seeing papilledema, we're not seeing the ophthalmologic stuff, but we are seeing pretty significant sinus stenosis in the spontaneous CSF leak patients, not as high as the IIH patients, but still up there. And, unlike the IIH patients, encephalocele rates for almost all of the patients that we're treating with CSF leak had encephaloceles, whereas in the IIH group, a minority of patients actually had a diagnosed encephalocele. So there's something, again, not sure what we are dealing with. Is like, why, if you have high pressures, why do the classic IIH patients don't develop, these consistent skull-based findings with, CSF leaks and encephalocele, but the spontaneous CSF leak patients do. We're hoping we're going to be coming to more answers over time, but I thought I'd share that these were our findings so far. So if we look specifically at the temporal bone CSF leaks, spontaneous or idiopathic CSF leaks, we found 119 patients, and the vast majority of them underwent surgical repair. Some were lost to follow-up, and some were, that deferred surgery, but the vast majority were treated with surgery. Again, no surprise here, the vast majority females. The state of Georgia is about 30-35% African-American, and so we see that representation here. And most of them had BMIs that were elevated, which is what we typically see in these circumstances. And of those patients who underwent surgery, we are biased in that we primarily address these in middle cranial fossa approach. They tend to have multiple defects. It's rare for it to just have one that is leaking. And so I defer in the treatment primarily for that. That way we can surveil the entire skull base. And again, if it's a patient that we suspect IIH, we have access to microscope where we can, just extend the craniotomy and assess that area as well. And some of them do require a combined approach. If you have a big lateral tegment bone deficiency, sometimes it's nice to have access to both sides to help your multi-layer reconstruction, because that's really important key point in these patients. If you're going for a CSF leak, you don't just want to use one medium. You want to use bone, cement. You want to use their own, bone plating that you can develop from their own craniotomy, or you can use, I personally use fibroperiosteal pedicle flap from the temporalis and some fascia and bone cement. So you just kind of really want to have multiple layers there to give you a long-lasting reconstruction. And if you look at the MRV findings specifically for the temporal bones or lateral skull base patients, it's a smaller number here because, again, we hadn't been getting MRVs in all of these patients up until several years ago. But, 50 in comparison to the big group is very similar. Majority of patients had bilateral transverse sinus stenosis. And surprisingly, we had, optic sheath dilation. 46% of the patients had that, which is, it's not an insignificant number. And then mitral cave dilation, 42% of the patients as well. So again, it's important to take the global picture when you're managing patients with spontaneous CSF leak. Not every CSF leak is going to have, IIH or you're going to be suspicious of this, but it is part of that mental algorithm you should go through. Now, another study that we did is we looked at the patients who had been treated for CSF, leaks, otorrhea, and we said, what is the prevalence of radiographic superior canal dehiscence? And why is that important? Is that, well, we know that there's a diffuse thinning of the tegment in patients who, often have this presentation of CSF leaks, and sometimes they have IIH. The bone is not great in the skull base, so let's see, when do we actually find canal dehiscence in this population? It's also important to know that especially if you're going through the middle cranial fossa, as you're elevating the dura of the bone, if you have a grossly dehiscent semicircular canal, you gotta be extra careful not to disrupt the endosteum of that canal and potentially make someone symptomatic, or even open up the endosteum and cause a hearing loss or even a deafness. So we always look at our imaging carefully for that, and I'll give the neurosurgeon a heads up. We're always together, but be like, hey, this is a grossly dehiscent superior canal. We got to be extra careful with our dissections. And so it's one of those points we always bring up at the beginning of our surgeries, because I do these with neurosurgery. So in this group, the study, we included patients who had undergone surgery for encephalocele or CSF leak to temporal bone. And we used controls the controls were actually patients who'd undergone otologic surgery for chronic otitis media or cholesteatoma, but we used the control as their contralateral ear that was not affected. And so that was the control group we used. Like, both groups had undergone surgery, but for different indications. And what we found was actually, I'll go to this. What we found was that the mean age of the study subjects, so those who underwent CSF leak repair or meningocele repair, the mean age was around 54, which is similar to the controls. Again, these are patients that had undergone chronic ear surgery, but were using the contralateral non-operated ear as a control. And then primarily female. I'm not sure, we try to match that the best we could. And the BMI was actually, as not surprising, much more elevated in the CSF leak or meningocele group compared to the non-CSF or meningocele group. And our findings were interesting. We found that if the patient had a mastoid encephalocele and a CSF leak, there was a almost 31% incidence of radiographic superior canal dehiscence. So that's not insignificant. If the patient had an encephalocele or a CSF leak, that number was lower, and the incidence of the radiographic dehiscence was only 3% in the control group. So this is obviously a significant finding. So that's just in our patient population, and I would think that our patient population is similar to those who are being treated for CSF leaks elsewhere. And so this is another radiographic representation of those findings. And finally, pulsatile tinnitus, right? These patients who we all see lots of pulsatile tinnitus. The diagnostic algorithm for it is really large, and we have very specific protocols for the imaging that we order for pulsatile tinnitus that is beyond, unfortunately, the confines of this talk, but I'm happy to provide that to others if they want to send me a message. But if we have, unilateral pulsatile tinnitus, we start with the CTA, CTV protocol that has fine cuts to the temporal bone. So it's almost like 3 studies that we are able to get. We look at the arterial venous system, and we look at the temporal bone morphology and development with the fine cuts to the T-bone. And so that's what we go through. But if it's, again, patients who have the IIH or suspected IIH tend to have bilateral pulsatile tinnitus, but not always, right? About 2/3 of the time. So this is just, I like to show this slide here because it kind of goes through all the things we have to think about with patients with pulsations in their ear or their head, which is quite a diagnosis to go through. And a lot of these, if between a physical exam and a CT, even CT temporal bone alone, we can, rule out a lot of these things in auscultation of the neck and the mastoid. So, and we're going to have a few minutes for questions, but in summary, it's important to know about IIH because the obesity rates are, going up everywhere in the world and in the US. And as a result, the diagnosis or, of IIH is going to be increasing. We're going to be seeing a lot more of these patients in our clinics. And, we know there's this association between idiopathic intracranial hypertension and spontaneous CSF leaks. And we are therefore going to be treating more of these patients with surgery, which is, the gold standard to treat a CSF leak from either the nose or the ear. And we are in a specific, very strategic position to be seeing these patients. And, it's important to establish those collaborations with relevant stakeholders like ophthalmology and neurosurgery, because oftentimes, and nutrition, because oftentimes these patients really need a multidisciplinary approach. And with that, I say thank you so much.
Hello, my name is Dr. Kevin Peng, neurotologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.